All right, good morning, everybody. My name is David Stahl. I am a clinical professor at Stanford University, and we are going to be talking about one of my favorite topics today, which is fluid management. We all know that fluids are the most common medication that we administer in the practice of anesthesiology, and so our topic today is Oasis or overload, mastering fluid choices in anesthesiology. I'm going to introduce our two incredible expert speakers today. Dr. Bellamy. Melissa Bellamy is an assistant professor of cardiothoracic anesthesiology and critical care medicine at the University of Texas Southwestern. She's a graduate of Harvard Medical School, followed by completing her anesthesia residency, chief residency, cardiac anesthesia, and critical care fellowships at Vanderbilt University Medical Center. Her professional interest is in medical education, and she currently serves as the residency rotation director for cardiac anesthesia, as well as the assistant program director for the critical care medicine fellowship. Her clinical interests are in right ventricular failure, pulmonary hypertension, heart and lung transplantation, where you can imagine fluids play an integral role. And she has spoken nationally and internationally on these topics, as well as the management of VA ECMO and the point of care ultrasound. Dr. Amy Kloosterboer is a clinical assistant professor in the Department of Anesthesiology, Perioperative, and Pain Medicine at Stanford University. She earned her medical degree at the University of Wisconsin School of Medicine and Public Health and completed residencies in both internal medicine and anesthesiology at Stanford University. She continued at Stanford, where she completed a fellowship in critical care medicine and has an interest in the perioperative management of liver transplant patients and is on our liver transplant team, as well as serving as the associate program director for our anesthesiology residency program. So I want to welcome Dr. Bellamy and Dr. Kloosterboer. Our objectives for today are going to be to explore some of the evidence behind goal-directed fluid therapy, to look at some clinical scenarios and think about what type of fluid is best supported by evidence to give, and how to think about restrictive fluid strategies in the perioperative setting. We are going to use an audience response system to keep this interesting. So if you haven't already, if you want to go to this website, anes25.cnf.io, you can point your phone at that QR code, or you can go in the app to this session in the meeting and click on Q&A or polling. So let's give it a shot here. For the football fans in the room, who do you think will be ranked number one at the end of the college football season? I like the early votes for Stanford.
Thank you for the Michigan vote.
Solid spread as expected.
Did you make the bar red on purpose?
A little bit. All right, I'm going to turn things over to our panelists.
Okay, so we're going to do this in kind of a case-based format. So our first case is a 73-year-old, 80-kilo woman who is undergoing a laparoscopic right hemicolectomy for colorectal cancer. She was told to be NPO at midnight, the way many of our patients are. She actually followed instructions, last ate dinner at 5 p.m., but had a sip of water with her evening meds at 8. But of course, due to some shenanigans in the OR, her case was delayed until 2 p.m. So the question is, does this change in her NPO status or this duration of her NPO status impact our fluid management plan? And I'm going to say, no, it does not. I'm going to tell you why not for multiple reasons. First, our estimates of fluid needs are incredibly inaccurate. And then NPO status doesn't in and of itself actually meaningfully decrease intravascular volume or create an excess fluid deficit that needs to be recovered. Last but not least, we're going to go more into the clinical effects and actually prove to you that if cases are delayed, it doesn't really change how much fluid they need in the OR. So our estimates of fluid needs are inaccurate. Vital signs obviously don't detect them until you're severely dehydrated, which most of our patients aren't after just being NPO since midnight. Physical exam findings are a little more sensitive, but still require pretty significant volume deficits in order to be detectable, which again, these are not most of our patients. We can get a little more accurate once we start getting serum or urine lab studies to see if we can detect blood volume status and how dehydrated patients are. But you can imagine how difficult it is just to get a urine pregnancy test in the morning for half of our patients, let alone getting a UA or spec grav on all of them to figure out how dehydrated they were, just in terms of planning. So a lot of times we rely as anesthesiologists on sort of volume loading recipes, which residents will quote to us. The 421 is a very famous one that they'll quote, which in this case would be 2.5 liters, which is kind of crazy to think about starting just a regular lap hemicolectomy with 2.5 liters of crystalloid. This was based on literature from the 1950s in pediatric patients that is actually proven in adults to provide way too much fluid, but yet this still remains. Sometimes you'll hear 2 mLs per kilo per hour of fasting, which again is over 3 liters in this case, which seems kind of crazy. So a lot of times you'll hear people say, just give them about a liter, make up for whatever happened overnight. But again, these are all just kind of gestalt, not actually based on any evidence. So going back to the original, always quote the Anesthesia Bible, Miller says the effects of preoperative fasting also should be considered, although its influence on fluid balance has perhaps been overstated. So just to prove that, again, MPO status does not decrease intravascular volume, I'm going to go through multiple different metrics of how we assess volume status, which is, of course, 99% of what we talk about in the ICU. So this was a study of healthy patients that started fasting at 10 o'clock at night, and then they were measuring their body weight and their urine output throughout the course of the evening until 4 p.m. the next day. And you can see that as time progresses, that their urine output actually decreases because the body is smarter than we are and knows to retain free water. So using volume status just on body weight alone, not a huge difference if they're MPO for 8 hours versus over 12. What about if we have not healthy patients? So this is a study that had patients that were healthy and also patients that had heart failure. And they were looking at weight and hematocrit, and no difference based on MPO status if they were fasting for 12 or more hours. Getting into fancier techniques, this was using ICG-labeled RBCs, and they were doing estimates of total body volume, and then they actually measured it when people were MPO, and there was no difference between estimates and what they actually measured based on MPO status. Also an ICU favorite, gotta get some TTE in there. So this was assessing volume status using just basic static metrics in terms of blood pressure and also dynamic metrics, VTI and passive leg raise. And there was no difference in volume status based on MPO status based on TTE measurements. And then going to the most invasive metric that we have, measuring true LV end diastolic pressure. So these were high-risk patients undergoing cardiac cath, so high risk of AKI, and they did direct measurements of LV end diastolic pressure. And if they were MPO for less than 10 hours or over 14, there was no difference in one of the most invasive metrics of volume status that we have, LV end diastolic pressure. So you're going to ask me, why is this possible? Everyone keeps telling me, we need to keep giving fluids. And it turns out the human body is smarter than we are. So like I said in the initial study, that we're able to retain that free water, but also we have pretty significant capacity to have transcapillary refill and move our interstitial fluid into our vascular space. This is why all of our patients, after they get dialysis and get 3 liters pulled off, don't immediately syncopize on the floor and get admitted to the ED. So then the question is, clinically, how does this really manifest? And so this is an interesting study where they looked at cases that were either first case start at 7:15 or were delayed until later in the day, and everyone had the same MPO recommendations. And then they had a very stringent protocol, this is at UC Davis, where they used stroke volume variation and different philosophies on colloid versus crystalloid. So all, in theory, the fluid management should have been the same. The only thing that was different was the MPO duration, and there was no difference in the fluids that were required for appropriate resuscitation in this case. So I hope I will prove to you that MPO status does not matter.
All right, and I'm here to take the other side of the coin and argue, yes, this patient shouldn't have been NPO since midnight. That's much too long. The deficits from MPO are really poorly studied. Things such as indocyanine green and tagged red cells, like my colleague talked about, are not the most accurate. NPO time does lead to relative hypovolemia, which then causes malperfusion and ultimately organ injury if it goes on for too much longer, and organ injury is bad, right? So let's look into some of the studies, but let's first take a trip through history. So dating all the way back to the 1880s, the first discussion of MPO status goes to Joseph Lister, who allowed his patients to have tea or beef tea up until 2 to 3 hours before surgery. And then this was first really studied in the 1940s when Mendelssohn looked at pregnant patients and found that of 44,000 patients that he took care of with general anesthesia, 66 of them aspirated, and 2 of those who died had had a full meal within 6 to 8 hours. And so this 6 to 8 hour window was born. In the 1960s, they went ahead and just said, you know what, let's make it NPO at midnight. And then today, NPO at midnight persists, even though we have much more data and even guidelines, because scheduling is easier when you tell everybody in preoperative clinic, just stop eating and drinking at midnight, just in case your case gets bumped up or we have to move things around. So again, just summarizing what I said, vital signs, physical exam, all of these things that we use to estimate volume status are not the most accurate, maybe a little bit more so when used in combination, and there's pretty extreme confounding, and the ways that we can measure, forgive my typo, are not the most accurate. Most of our patients in the OR, like my colleague mentioned, don't get a protocolized goal-directed fluid strategy, and they're NPO for much longer than they need to be. But at least we know how long they've been NPO, and we can use that to somewhat estimate the amount of fluids that they need. Again, this just demonstrates the physiology I was discussing earlier. Patients are NPO for a certain amount of time. Eventually, that causes some relative hypovolemia, malperfusion, and ultimately organ injury. Thankfully, most of our patients do not end up in that last category. So this is a study where they looked at 3 groups of patients undergoing mastectomy, open abdominal surgery, and radical prostatectomy. And everybody got a 200 cc bolus to start with. And then they used measures like stroke volume variation and change in stroke volume to determine whether or not the patients were volume responsive. And until they were no longer volume responsive, they repeated these 200 cc boluses. And each additional bolus is a darker color. So you can see here that up to 70% of patients were actually fluid responsive. And that's even more magnified in the open abdominal surgery and radical prostatectomy group. And these patients underwent a bowel prep, which is something that we didn't mention earlier, but also worsens your fluid deficit when you're NPO. Another outcome that's important to us is postoperative nausea and vomiting. So this is a study of patients who, if they were in the large volume group, which is here in black, received 2 mLs per kilo per hour of fasting. That's kind of that large group that my colleague mentioned earlier, versus the control, which received 3 mLs per kilo, regardless of amount of time fasting. And they looked at several time points after surgery. So this is immediately in the PACU. Sorry, my hair's hitting the mic. This is in the PACU. And then we have 1 hour, 4 hours, 24, and 72 hours. And at every point, the group that received fluid per hour of fasting has a lower incidence of post-op nausea and vomiting. Another outcome that we care a lot about, especially in cardiac land where I come from, is AKI. And this is a study that she mentioned earlier of cath lab patients. And you can see with everything else controlled, the NPO time increases here on the x-axis, and there's a direct correlation to the increase in creatinine with increase in NPO time. This is a study, kind of a catch-all. They looked at a number of postoperative outcomes, respiratory, renal, GI, cardiovascular, neurologic outcomes, and looked at patients that were euhydrated, patients that received volume based on how long they'd been NPO versus patients that received standard of care and were considered dehydrated. And all of these secondary outcomes, with one notable exception of infection, were increased in the dehydrated patients. And then this is a consensus statement here. You may recognize a couple of the names on this paper. People from across the United States and Europe got together and came up with a set of guidelines and recommendations for perioperative fluid management. We'll refer to these throughout the talk today, and we'll highlight the ones that are important to the particular question we're trying to address. And so here are all of the guidelines. It gives you the number of people on the panel that voted for it and the percentage of agreement. But what's relevant here to this question is they actually recommended keeping fasting time short. If you take nothing away from my part of this talk, is that NPO times are important. And even with our ASA guidelines now, we allow clear liquids up until 2 hours before surgery. And I feel like that's especially underutilized and probably the best way to keep our patients hydrated and achieve some of these outcomes without having to give a lot of IV fluids with all of the side effects that we see with that. So let's test our poll. Based on our debate today, does the NPO status impact your fluid management plan? Do I click to the next slide?
Yeah, click one more. There you go.
All right, let's see what we got. All right, well, thank you guys, much appreciated. So, did you want to do take-home messages or you want me to? Okay, sorry for all the questions. Take-home messages for NPO, like our ability to estimate fluid status is just not great using the technology that we have. Fluid status or even fluid responsiveness is not necessarily an indication to give a predetermined amount of fluid. What's most important is decreasing NPO times and allowing patients to self-regulate and take in clear fluids up until a couple hours before surgery. All right. So I'm going to stay up here and go through our next case. So we have a 66-year-old, 80-kilo woman who's undergoing Whipple for pancreatic cancer. About 2 hours into the case, we're on almost a MAC of sevoflurane. She's received 1.5 liters of crystalloid, and she's had 140 mLs of urine output, and EBL's been pretty minimal to this point. She's on a phenylephrine infusion at 1.2 mics per kg per minute, and she's doing that to keep her MAP over 60. So should we give additional fluid to reduce intraoperative vasopressors? I'm here to argue yes. So anesthetics induce vasodilation, which makes our tank of blood volume larger. And one way to fill that tank is to give fluids. Anesthetics don't necessarily make our smooth muscle more permeable, so that fluid isn't necessarily going to leak into extravascular tissues. Vasopressors, they do bring the blood pressure up, but they can mask some underlying hypovolemia, and we really need to optimize that Frank-Starling curve, which of course I will show you guys. And then vasopressors, especially in high doses, come with their own host of complications. So this is a graph here of our body's intrinsic ways to maintain blood pressure and the effect of different kinds of anesthetics. So we have our inhaled anesthetics, barbiturates, our non-barbiturate drugs such as propofol, etomidate, the ones we're most commonly using, benzos and opioids, and the effect that they have on all of these intrinsic systems of maintaining vascular tone and blood pressure. This is a study where they looked at rat lungs and they looked at permeability to albumin here on the y-axis with different concentrations of inhaled anesthetics. So there's a control with no anesthetic, isoflurane at 1 MAC, isoflurane at 2 MAC, sevoflurane at 1 MAC, and sevoflurane at 2 MAC. And as you can see, unless we're using really large amounts of isoflurane, not many of us are using isoflurane that much anymore, and especially not at 2 MAC. This is the only situation where they were able to demonstrate increased permeability. And I promised you a Frank-Starling curve. Here we are. So in both patients with poor ventricular function and normal ventricular function, as we're going to assume that our theoretical patient has, we really need to capitalize on this part of the curve. In patients that are NPO prior to surgery, they tend to be on the steep part of the Starling curve where you get more bang for your buck by giving a small fluid bolus. And we have much different ways of measuring volume responsiveness now. And so in our patients, it is reasonable to try giving a fluid bolus to increase our stroke volume and cardiac output before immediately starting vasopressors. This is another study. They looked at 80 patients undergoing elective major abdominal surgery. They were randomly assigned to a control group, which is standard of care, versus a goal-directed fluid group. They used stroke volume variation here to determine whether a patient was fluid responsive and gave fluids accordingly. And the patients who were resuscitated in a goal-directed manner tended to be on half the dose of norepinephrine at 3 hours into surgery as those who did not. So we're able to decrease the amount of vasopressors required to maintain normotension by using the information that we have and using goal-directed fluid management. This is another study looking at major abdominal surgery. Patients were randomized into the PVI group, so they used the pleth variability index as their marker of fluid responsiveness versus control group. And patients receiving fluids according to their goal-directed strategy at intraoperative 24 and 48 hours all had statistically significantly less lactate levels than those in the standard of care group. And again, another goal-directed fluid study, patients receiving standard of care versus goal-directed fluid management. There was a difference in length of stay in those who were on inotropes and presumably received fluid to get off of the inotropes and vasopressors. And there's a trend towards significance and decreased length of stay in those who weren't on inotropes or vasopressors, but presumably these patients are a little bit healthier at baseline and we're probably going to have a shorter length of stay to start with. And vasopressors have consequences. So this is the relief trial that you guys may have seen, and it randomized patients to a liberal versus restrictive fluid strategy. And I want to draw your eyes here to AKI. And this is a very important outcome that we look at that has effects on patients long term. Patients who were in the liberal fluid group had decreased incidence of acute kidney injury and trended towards significance for renal replacement therapy as well. Going back to our trustee guidelines, I want to draw your eyes here. This is an interesting one. It did not have as much consensus as the other guidelines here, with only 62% recommendation. But I think that the end of the statement is what caused the ambivalence. So they recommended intraoperative administration of an adequate amount of fluid, generally aiming for a positive fluid balance of 1 to 2 liters. I would argue that we should use our measurements of fluid responsiveness and use a goal-directed strategy and not just shoot for positive of 1 to 2 liters. And I will hand this over to my colleague to argue the other side. Thank you.
Okay, unlike Dr. Bellamy, I don't think fluids are the savior for everything, and I don't think pressors are the devil. So vasopressors in and of themselves do not necessarily worsen clinical outcomes. If you use them to aid in malperfusion, that's what gets you. So fluids are a drug, just the way vasopressors are, and if you use either of them poorly, you're gonna cause some problems. And I do agree with her that intravascular volume should be optimized before adding pressors, but just because they're vasodilated under anesthesia doesn't mean you should fill that tank. So again, after you rule out hypovolemia and cardiac dysfunction, vasopressors are going to be our option of choice, just given the vasodilatation that happens with most of our anesthetics. So the study that she pointed out so wonderfully, while there is a statistical significance, I would say, what's the clinical significance of a lactate of 1.5 versus 1 in PACU? Particularly knowing that fluids can cause harm as well. And you have to then de-resuscitate the patient, risks of ileus, edema, patient discomfort postoperatively. Also, if they're used poorly. So this is an interesting study where they were looking at 160 patients that were undergoing elective major abdominal surgery. And they were, again, using standardized protocols in terms of when they start vasopressors, how they volume resuscitate, and then actually looking at cardiac index to think that maybe it's not just a vasopressor and maybe we should actually be using inotropes. And so when they used their protocol, you can see that they found 33 people actually needed to be started on dobutamine just to optimize their cardiac index. And so our baseline of just starting, norepinephrine or phenylephrine on everyone maybe is not necessarily our best option, and maybe we need a little more beta, so that maybe it's not fluid, but actually the inotropy that we need instead. So back to this relief trial that she talked about. So this was over 3,000 patients that were undergoing major abdominal surgery that were put in a restrictive arm versus a liberal fluid arm. And I think the most important thing about this trial is when you look at the restrictive arm, some patients actually were volume negative, which think about the last time you ever had an open abdominal surgery and you took away at the end of the day that the patient was negative. That's kind of crazy to think about, right? So the risk of AKI makes sense because that's not actually how we'd usually clinically practice. And even with that, of keeping some of these patients negative, they only had 4 patients that required renal replacement therapy post-op and 13 that had an AKI out of 3,000. So just things to consider. Pressors are maybe not the worst thing. So when we're thinking about fluid, we just really need to be deliberate. So there has to be some sort of evidence of malperfusion, not just hypotension alone. You have your hypothesis that it's hypovolemia, you give volume, and if you have an increased stroke volume and cardiac output, then yes, make sure you're appropriately volume resuscitated. But if you're no longer getting bang for your buck, stop, and pressors are totally okay to start. Okay, poll time again. Should you give additional fluids to patients requiring intraoperative vasopressors? Oh wait, why didn't it work? Is it going? Okay, sorry. Tight race. Okay. So I think it's a little more complicated when we get into specific situations. So the plot thickens a little bit. So instead of that case that we talked about before, we have a 42-year-old healthy woman undergoing bilateral deep flaps for breast reconstruction. Again, has gotten 1.5 liters of crystalloid. She's had a decent amount of urine output, minimal blood loss. And the surgeon looks over the drapes and see that she's on phenylephrine stills and says, "Oh my God, what are you doing? Your pressors are going to kill my flap." So this was a large systematic review and meta-analysis that came out in 2023 that shows that vasopressors may actually help. Because turns out that the perfusion to the flap is the same thing as the perfusion to the heart, as the perfusion to the brain, everything else that we're caring about. And pouring in 6 liters of crystalloid to make a surgeon happy may not actually be the best thing for perfusion of the flap. And so these were all free flaps as well too, so higher risk. So just feel empowered to know that perfusion of all the organs that we care about is also going to be perfusion of the same organs that they care about, and your pressors will not intrinsically kill their flaps. Same patient, different surgeon. Same 42-year-old healthy woman, but this time undergoing a partial hepatectomy for HCC. Patients on the same amount of pressors, but surgeon peers over the drapes this time and says, "Oh my God, you gave 1.5 liters of crystalloid. What are you doing? My patient's going to bleed out." So this we know, restrictive fluid strategy during hepatectomy does lead to decreased blood loss and improved perioperative outcomes for our liver patients. And this, again, is just on the restrictive. There's no additional benefit for causing additional vasodilation, doing things like nitroglycerin or anything on top of that. But this has actually been pretty significantly proven. This is a large systematic review that came out in 2021, but pretty significant population sizes. The thing is, though, is that they still do need some fluid. The question is how much and when do you decide to give it? So this is a study that came out in 2024 where they were looking at a restrictive group of fluid resuscitation and hepatectomy patients where you were only allowed to give fluid if the patient was hemodynamically unstable. And then the other group was the decision support group where they looked at multiple metrics in terms of volume status, and they actually fed you information saying like, hey, we think your patient is volume responsive, you should give a little more. And turns out markedly improved lactate levels both intraoperatively and postoperatively if you used this decision support tool. And I think the most interesting thing is between the two arms, there is only a 500 cc difference of volume that was administered. So that maybe we don't need to wait until the patient is completely hemodynamically unstable to give some volume, and small amounts of volume can be enough. Notably in this study, there is no increased incidence of transfusion requirements or bleeding, and then no change in overall mortality or outcomes. So while we do still want to be fluid restrictive and be really cognizant and thoughtful to our surgical colleagues, maybe to the point of being hemodynamically unstable is a bridge too far. Last but not least, you have another healthy person who had perforated diverticulitis and is undergoing exploratory laparoscopy, came directly to the OR from the ER. MAP is 58. You're going in the case, she's gotten 3 liters of crystalloid since she came into the ED. 150 mLs of urine output, lactate is 3. She's on pretty significant doses of norepi at 0.18, and the surgeon is looking over you saying, please get them off of norepi. I want them to go to PACU. I have more lap choles to do, and I don't want to be in an ICU hold. So the question is, how do we volume resuscitate in sepsis, and how does this affect us in the OR? So CMS guidelines will reimburse you based on the 30 cc's per kilo that they need to get within clinical concern for sepsis or septic shock. And the question is, where does this come from? So this was a large retrospective study of over 9,000 Kaiser patients that had presumed sepsis and intermediate lactate levels between 2 and 4. And they were trying to figure out where kind of the sweet spot was where their mortality was the lowest. And they found that this is around 30 cc's per kilo. When you went a little less, again, mortality started increasing. Same thing when you went a little hog wild with the volume. So this is where a lot of this is based off of. Now, again, you can document clinical reasons not to give additional volume and meet CMS guidelines, but this is where it comes from. So we often in the OR do not see these patients right away, right? That's in the ER, that's on the floor, and then they have some sort of surgical concern. They've been appropriately volume resuscitated with their 30 mLs per kilo, and then they come to us, and the question is, what do? We know they're already vasodilated. They're going to get more vasodilated when we give them anesthesia, so how do we deal with this? And we don't have great trials for the septic shock patient in the OR, so we use a lot of our ICU literature. So we've had a couple large randomized controlled trials that have come out in the past couple of years, most recently Classic and Clovers, which was restricting or keeping people on more of a fluid restrictive side of things versus a more fluid liberal side of things after that initial resuscitation period. And turns out there's no huge difference between either arm. So this is where, again, using our markers that we're talking about in terms of clinical signs and symptoms of volume responsiveness, and if they're appropriately volume resuscitated are really important. But I think just volume responsive is not enough anymore. You also have to think about if they're volume tolerant. And so the patient that's on 80% FiO2, I'm much more likely to go towards the restrictive side of things versus a healthy person that's on room air that I think I can probably get off of pressors and maybe they can handle 1 more liter. It's a slightly different metric when you're thinking about that. So overall, is this perioperative septic patient different? In some ways, probably, because they're a little more vasodilated, they have more inflammation going on, but also we need to think about them in the same ways that we're thinking about all of our other intraoperative patients. So big take-home messages, vasopressors in and of themselves are not necessarily associated with positive or negative clinical outcomes. If you use them poorly and are using them on someone who isn't appropriately volume resuscitated, it will definitely lead to worse outcomes. But again, MAP and volume status alone do not equal perfusion, so making sure that you're thinking about the whole patient. And that fluids should be used very deliberately and know that you're prescribing them the same way we're prescribing all of our other intraoperative medications. Okay, next case, we have a 73-year-old person undergoing a laparoscopic right hemicolectomy for suspected cancer. The resident decides to choose plasmolite, saying that plasmolite is from the Champagne region of France and all the rest are just sparkling crystalloids. So the question is, do balanced crystalloids improve outcomes compared to normal saline?
That's very presumptuous of your resident from the Bay Area. Okay, I'm here to argue, yes, that balanced crystalloids do improve outcomes compared to normal saline. And that's mostly because of the metabolic derangement that you get with normal saline that's somewhat mitigated by giving these balanced solutions, lactated ringers or plasmolite. The risk of AKI has been demonstrated to be decreased in several trials that I'll present to you guys. And there's also a demonstrated mortality benefit in patients without TBI. So let's talk through some of the basic presumptions that we make with balanced solutions versus normal saline. Balanced crystalloids have sodium, potassium chloride. They're much more representative of human plasma than the classic normal saline, which is just 154 milliequivalents of sodium, 154 milliequivalents of chloride, and is a hypertonic solution relative to human plasma. Because there's been some concerns for the development of AKI with large volumes of normal saline, there's really been a push in the intraoperative community to use balanced crystalloids. So this is a trial, a prospective open label trial where they had 760 patients admitted to an ICU, and they looked at 2 periods. So for the first year, patients received all types of fluids. They had a 6-month washout period, and then the next year, they only received balanced fluids, demonstrated here by the non-X'd out columns. And they looked at renal injury, and they used the rifle criteria, as well as the incidence of renal replacement therapy and renal failure in these patients. And they found patients who received balanced crystalloids had decreased incidence of injury and failure according to the rifle criteria, so decreased AKI, as well as slightly less renal replacement therapy as well. So let's look at some of the major New England Journal studies. Let's start with the SALTED study. So this was done at Vanderbilt in non-critically critically ill patients. And they did a block randomization. 1 month, all of these patients would receive normal saline. The next month, all of the patients would receive plasmolite or lactated ringers. And they looked at a number of outcomes. So here is the subgroup analysis. They looked at the mean difference in hospital-free days. Get my cursor going over here. And they also looked at major adverse kidney events and AKI. And they found that overall, there was a decreased incidence of MAKE or major adverse kidney events in patients receiving balanced crystalloids versus normal saline. And in patients who already had elevated creatinine coming in, there was decreased incidence of kidney events and AKI in those patients with balanced crystalloids. And the same was demonstrated in people who were hyperchloremic coming into the hospital as well. Okay, so that was non-critically ill patients. The same group later on looked at critically ill patients. So these are patients that they knew were going to the ICU. Same randomization strategy, normal saline 1 month. I was a resident when this happened, and we had fluid carts in the OR, and they literally had an X taped on the ones that we weren't supposed to give. So I think they had pretty good adherence to their randomization strategy here. And they looked at major adverse kidney events and in-hospital mortality. And they found a statistically significant difference in major adverse kidney events with an improvement in those receiving balanced crystalloids and a trend towards significance in mortality at 30 days in those receiving balanced crystalloids relative to normal saline. And here's a subgroup analysis. Just want to draw your eyes here. This is looking at a composite outcome of death, new renal replacement therapy, or persistent renal dysfunction. And in patients who were septic and patients who had previously required renal replacement therapy, it favored using balanced crystalloids. And then we'll talk about this a little bit later in the talk, but patients without TBI also had an improvement in this composite outcome. This is a subgroup analysis done later from the SMART trial that we just discussed, and this is looking particularly at septic patients. It was kind of kick-started from that subgroup analysis. And in septic patients, they found that there was a reduction in 30-day in-hospital mortality in patients receiving balanced crystalloids relative to normal saline. And the journal actually put this as a bullet point to take away that in our septic patients, there's a growing amount of evidence that we should really reach for balanced crystalloids. This is another meta-analysis that was just published this summer in ANA, looking at patients who were treated with balanced crystalloids versus normal saline, and specifically patients without traumatic brain injury. And again, they showed a mortality benefit of balanced crystalloids. This is 90-day mortality. And notably, I want to draw your eyes here to the second line. There was actually an increase in mortality in patients with TBI who received balanced crystalloids. We should be giving these patients normal saline. Going back to our trusty consensus statement, we're going to zoom in on the important part here. So they, in very, very high numbers, or maybe one or two dissenters in the group, we should be giving our patients buffered crystalloid or balanced solutions. All right, I'll hand this over to Dr. Clusterbauer.
Okay, so she just told you lots of really great things about the kidneys, but most of our patients in the OR are not patients that are critically ill or septic, and most of them are not getting nearly the amount of volume that a lot of these patients are. So in most of our patients, again, this is not necessarily applicable, and I do agree there are the rare critically ill patient that may have a special indication for one type of fluid, but that's not most of who we take care of. This was the systematic review and meta-analysis that she talks about, and this is intraoperative use of balanced crystalloids versus normal saline. And not to bury the lead, but there is absolutely no difference in outcomes in terms of renal replacement therapy and mortality, which are two outcomes that I care about more than AKI. Now, I do agree with her that you do get more metabolic acidosis with normal saline. The hyperchloremia causes a non-anion gap metabolic acidosis. So we can prove that. In this same study, they showed that there was a lower post-op bicarb level. They had higher chloride levels, which is consistent with how we know normal saline works. It's just a matter of if it's actually clinically significant to us or not. So even in the study talking about critically ill patients, she says it, trends towards significance, but that's not technically significance. And so I will say there was no statistically significant difference in mortality between those two groups. But again, proving that chloride is doing what we think it is, that in those groups you can see that the chloride concentrations were markedly lower if you had balanced crystalloids versus normal saline, and your bicarb was higher if you had balanced solutions. But again, if it doesn't lead to mortality, I'm not sure if it matters to me as much. The TBI group she talked about also makes sense if you require normal saline. You don't want to have to worry about increased swelling in the brain. So that's always going to be kind of a special subset. And even in these trials, the way they were designed, clinicians were allowed to exclude TBI patients if they were concerned about them. So this is also a biasing factor in the study. So we're going to take that with a grain of salt, pun intended. And then this is one that came out in 2021, a large study of over 10,000 patients, randomizing patients to balanced solutions versus saline, and again, no difference in mortality. Same thing, slightly different flavor. This was in New Zealand and Australia, over 5,000 patients, death, new renal replacement therapy, or increase in creatinine. Again, no difference between the two arms. They just keep hammering at this because, you know, we really want to prove that balanced solutions are better. But this is a study that came out earlier this year about lactated ringers versus normal saline. And again, no difference between the two groups. And if you don't believe me...
Surgeon, where is my patient? I must operate. Hey, what's going on with surgery? He seems angrier than usual. Yeah, like last week I wasn't able to read his mind in the operating room, but this seems worse. Yeah, there was a trial recently published in the New England Journal of Medicine comparing lactated ringers to normal saline. Really? Yeah, over 43,000 patients were treated at 7 hospitals in Canada. Each hospital was randomly assigned to use either lactated ringer solution or normal saline for 12 weeks. The whole hospital. Then after 2 weeks, they switched to the other fluid for 12 more weeks. What did they find? At 90 days, the mean incidence of a composite of death or readmission to the hospital was not significantly lower with the lactated ringers group than with normal saline. And that makes surgery angry. Much of a surgeon's identity is tied to thinking lactated ringers is a superior IV fluid. This study doesn't show that. I don't get it. Why do they like it so much? Lactated ringers has electrolytes. They see it as intravenous Gatorade. Okay, so why is nephrology so unhappy? Do they also prefer lactated ringers? No, they pretty much dislike all IV fluids, but particularly normal saline. I don't understand. Why? Normal saline contains massive amounts of chloride, which can lead to hyperchloremic metabolic acidosis, which makes the kidneys sad.
So if you don't trust me, trust Dr. Glockenflecken. So do balanced crystalloids improve outcomes compared to normal saline? Again, asterisk to all of this, we are not necessarily arguing the sides that we believe. Okay.
Thank you.
So on to the next case. Similar case. This was same patient, laparoscopic right hemicolectomy for cancer, but this patient has CKD stage 4 and required CRRT after a prior surgery. So which fluid should we be giving this patient, balanced crystalloid or normal saline? Okay, and again, just emphasizing people that have already or have, you know, previous incidents of needing renal replacement therapy or CKD, they may be a subgroup that potentially benefits more from balanced crystalloids. What about the same patient, but they're coming in for an emergent hemicraniectomy for a traumatic subdural hemorrhage after a fall? Which fluid should we be giving this patient? Again, noting that a lot of the TBI patients were excluded in those initial trials, and there's potentially a signal for having a mortality benefit for them in using normal saline over some of our balanced crystalloids. So big take home is that there's no consistent intraoperative difference between normal saline and balanced crystalloids, how we usually use them for most of our patients. You definitely do get more acidosis and hyperchloremia with normal saline. Balanced solutions potentially may be more expensive, so things to consider at your hospital when you're weighing the pros and cons of which fluid you're implementing. So you're probably okay to use whatever salt water you would like to use, but in certain subgroups, particularly patients that are septic, critically ill, or previously had renal replacement therapy or already have CKD, maybe considering using balanced crystalloids a little earlier on them, and then considering using normal saline in patients that have TBI. Okay, same case. But this time, your resident is choosing albumin, stating that they like the way the bubbles look in the glass bottle. So the question is, does the addition of colloids to standard fluid resuscitation improve outcomes?
And we're really making the residents the bad guys here, but we all love education. So Okay, I'm here to argue that yes, colloids do, because they maintain the intravascular oncotic pressure better and longer than crystalloids, and you can use lower volumes of your colloids to maintain the same volume versus crystalloids, and we don't want to overload that extravascular space. So this is a trial here. We want to know if outcomes are improved by colloids. They gave hydroxyethyl starch as their colloid, disclaimer, in this study versus crystalloid. And the main point I want to make about this graph for the interest of time is that patients receiving colloids did get less volume than those receiving crystalloids. Again, looking at hemodynamic targets were achieved faster and with less fluid in patients receiving colloids relative to crystalloids. They were on less vasopressors, had less weight gain at post-op day 2, and then although we didn't achieve statistical significance, I just want to point out no difference in renal replacement therapy and less 30-day mortality, but because there were only 4 in the other arm, we couldn't achieve statistical significance. Okay, enough of hydroxyethyl starch. Let's talk about albumin. So this is a study that looked at crystalloid, hydroxyethyl starch, and albumin, and they assessed a number of things, looking at plasma volume, oncotic pressure, and stroke volume index. So these graphs, I want to draw your eyes here to albumin. Compared to bicarbonate ringer solution, albumin boluses resulted in a higher plasma volume, as well as an increased colloid oncotic pressure. That's what COP means, relative to the balanced crystalloids. And then here, what they did is they looked at stroke volume index, and patients receiving albumin, which is highlighted here in blue, relative to crystalloids, which are these circles and the dotted line that goes down like this. Not only did they have an increase in their stroke volume index, but they sustained that over time relative to patients receiving crystalloids who had an initial increase but then decline over 20 to 30 minutes. This is another study. It's a systematic review and meta-analysis of trials looking at ICU patients who were undergoing volume resuscitation with either crystalloid or colloid. And they looked at 5 different eligible randomized controlled trials, so almost 30,000 patients here, assessing outcomes of hemodynamic targets of resuscitation. Here we're looking at CVP and MAP, and I want to really draw your eyes here to the albumin group, showing that they did have an improvement in both of these targets. Here we go with CVP, and here we go with MAP, almost statistically significant. This is another study. We care a lot that we can meet our hemodynamic targets, but we care even more about things like mortality. So they looked at mortality in patients receiving albumin versus crystalloid and septic shock and severe sepsis. So our top graph here is patients with severe sepsis, and our bottom graph here is patients with septic shock. And the patients with severe sepsis trended towards statistical significance in favoring albumin. I know that Dr. Klosterbar is going to call me out on this. And then patients with septic shock really did have a statistically significant improvement with albumin relative to crystalloid. Okay, and I will hand over the reins.
I'll come back and do the case at the end. Okay, so most of the studies that are examining this question really ignore the risks of colloid and really overstate the clinical effects. And the improvement in hemodynamics, while it may linger a little longer, does not actually correlate to any meaningful mortality benefit or reduction in major adverse events. And then the other thing that a lot of times residents or trainees will bring up to you is like, oh yeah, but I get to use like a third less albumin than I do crystalloid, and none of that is actually based on large clinical trials, that number that they come up with. So again, hemodynamically, totally agree, you can reach your targets faster, but to what endpoint? And it doesn't actually lead to clinically significant changes for us. So the 1-to-3 conversion is really sort of a myth. A lot of the large trials with colloids, you can see them listed over here to the left, show the ratios, even at their best, are about 1.5 to 1. So yes, you're giving a little less volume, but not a hugely decreased amount of volume. So the landmark colloid and crystalloid trials you can see over here off to the left, a lot of these unfortunately use hydroxyethyl starch, which we know causes an increase incidence of renal failure, thrombocytopenia, and complications associated with that, which is why we do not commonly use it in the US. But even just in terms of the hemodynamics, you can see that there was no real benefit in terms of the colloids versus the crystalloids. But your question is always going to be, what about albumin? Because that's the one that we use. And again, no actual difference in mortality, which is the metric that I care much more about. Additional systematic review and meta-analysis that came out in 2024 of over 2,300 patients. And again, no difference between the two arms in terms of albumin and crystalloid in terms of kidney dysfunction, all group mortality, kidney dysfunction, and ICU length of stay. What about using it in the operating room in non-cardiac surgery? Again, no difference in mortality and actual potential odds ratio or increased risk of having AKI, severe AKI, and pulmonary events in groups that got albumin. So what do our recommendations and current guidelines say? They recommend against the routine use of albumin or synthetic colloid for intraoperative fluid administration. Now, sepsis is kind of a slightly different category, again, that we talked about earlier. So looking at the surviving sepsis guidelines, it's actually kind of interesting that their bullet points come across a little stronger than what you actually read further into the article. So they say they recommend using crystalloids as the first-line fluid resuscitation, which we just showed you the evidence for. But you can see later on, they say, for adults with sepsis or septic shock, we suggest using albumin in patients who receive large volumes of crystalloid. And I think this is always the question, is what counts as large volumes? And so when you read the finer points, they say that this recommendation is informed by evidence showing higher blood pressure at earlier and later time points, higher static filling pressures, and lower net fluid balance with albumin. So really, again, just improved hemodynamic endpoints, but no actual mortality benefit. And they even hedge on quantifying what that cutoff value is for crystalloid. So when trainees or someone talks to you about this, it is technically within the surviving sepsis guidelines, but again, they really kind of hedge and don't have any strong evidence behind their recommendations. So does the addition of colloids to standard fluid resuscitation improve outcomes?
You can sum it up and then.
I forgot about the summary slide. So again, big take-home message with colloids that there's no evidence of superiority of colloids to crystalloids in our standard clinical practice. I will say I use them a lot in my liver transplants, as we don't have to give blood right away, just because they're essentially getting a large volume paracentesis, which there is data for that. And you potentially may administer less volume, but it's significantly more expensive without any real marked mortality or kidney benefits. Again, caveat to some of the earlier studies is some of them, the colloids were hydroxyethyl starch, which we don't use in the US because we do know it has an increased risk of AKI and other complications associated with it.
So I have to bring this around to cardiac at the end. What about cardiac? Your resident says, this patient has severe TR, their RV is not quite normal. If we give albumin, we can give less fluid, and that will maybe help prevent volume overload or worsening RV failure in this patient. What do you think? I'm here to say no. So there's a couple of studies that come out recently that show that there's no benefit and potentially some harm from giving our cardiac surgery patients large volumes of albumin. So this was a study in JAMA that came out 3 years ago now, looking at patients who had their bypass circuit prime and their primary resuscitation fluid randomized to either 4% albumin or Ringer's acetate, which is kind of like lactated Ringer's, in patients undergoing cardiac surgery requiring bypass. And there was no difference in mortality, but they looked at a number of different outcomes here. My screen is really small, but we'll draw your attention here to major adverse events and to death, showing that there's really no difference in the major outcomes that we've been discussing today. But if you look at some of these other things like infection, resternotomy, bleeding, these bars don't cross the middle. There's actually a trend towards harm in patients receiving albumin in terms of needing resternotomy or bleeding or even infection. And this here just breaks down the secondary outcomes a little bit more. So no huge difference in the major metrics that we look at, but again, demonstrating increased chest tube output, increased need for transfusion, and platelet transfusion as well. So this raised some flags. And then the next year in the British Journal, Dr. Skubas did this systematic review, meta-analysis, looking at a number of different trials comparing crystalloid versus albumin in cardiac surgery, and again, demonstrated no difference in mortality or any of the outcomes that really matter. And so based on the available evidence, they're actually saying that we shouldn't give albumin because it's higher cost than crystalloids and may potentially have some harm. So are you going to give albumin to your cardiac surgical patients? Oh, I guess no. Try this again. All right. Thank you, guys. And then we will sum it up here. So if you've taken nothing else away from this talk, there really is no one size fit all. There is nuance to everything that we discussed. But it's really important that we use our brains and everything that we have learned in our training to assess patient status, whether that be volume status or their need for different types of crystalloids or colloids, what the indications they are for fluids, which type we should be giving them, and then considering alternative treatments such as inotropes and vasopressors to fluids. And we would like to open up the floor for questions. Thank you.
We are happy to take any questions. If you could use the microphone so the recording captures it, that'd be great.
Thank you for a great talk and discussion. I'm Paul Polyak from Michigan. One of the, I think, difficulties is evaluating patient volume status when you don't have continuous blood pressure, whether arterial line or non-invasive. Can you speak to microbolusing? There are some studies about that. Leg raise typically not practical. I don't think the surgeons would like it very much. So what, some of the impedance, it's not, that's more of a research tool. So what do you use? So you're doing a, big XLAP, but, not a lot of hemodynamic changes expected. Patient doesn't have a non-invasive continuous blood pressure. What do you use to evaluate how much volume you should give?
I tend to do an overall clinical gestalt. So I look at how long the surgery's been going, how much possible insensible loss we've had, what the urine output is. And then I try and go back to my physical exam pre. I'm obviously not doing a passive leg raise on these people, but if they have a history of heart failure, do they have some edema, et cetera. But then I will give a small fluid bolus. Now, I live in cardiac land where we are blessed to have TEE and can use different things to help with volume. But when I am in an XLAP, I will pretty quickly go to a small fluid bolus just to see if I get an improvement in my blood pressure or not. I don't know if you can speak more eloquently to that.
Yeah, no, same thing. And I think the nice thing about an XLAP is you actually have urine output. It's harder when it's laparoscopic, and you know
Yes.
that is kind of making your life a little more difficult. But I do think for me in the OR, because so many people we think they're a little more volume down. A lot of them have bowel preps and other things for giant bowel surgery, that they kind of have to prove to me that they don't need fluids first. So giving, a couple hundred cc's, I feel pretty confident that I can take that off, or by the end of the surgery, the surgeons will bleed enough that it'll be taken off in a different way. But it is really hard, and we have the non-invasive finger cuffs now, so you can kind of get SVR and other things from that as well. A lot of these people have art lines, PVI, you can kind of use different metrics. But to your point, I don't think there's a be-all, end-all for all of this, and that's why we keep having these talks, is because volume status is probably one of the most difficult things we try to assess every day, and there is no gold standard truly for how we measure it.
Yeah, like I teach the residents the fluid chart, but I preface it with it tends to overestimate, how much volume the patient actually needs, but it gives you keeps you in the range, so to speak. But it's difficult to pin down exactly how much to give.
Yeah, I really like the hepatectomy study that Dr. Klusterboer had presented, just because it made me feel like giving some small amount of fluid probably does actually have an impact, because I think there's a historical trend to feel like, if it's not 500 cc's, it doesn't matter. But also that it's okay to give it later in the case and not necessarily jump to giving big volumes up front. And obviously hepatectomy doesn't extrapolate to every other type of abdominal surgery, but I feel like that at least gives you an insight into how to manage that uncertainty for all of us. Any other questions?
Great talk, thank you. I feel like historically we've overestimated probably what like the hourly and sensible losses for in laparotomy. How do you guys like to think about that?
I think it's kind of the same answer that I gave before. And I do think, you know, so much of it when they are doing giant laparotomies tends to accompany blood loss, and so then you're kind of manipulating many things. But I don't think necessarily having an open abdomen changes that much more, besides realizing that you're probably losing a little more. But I don't necessarily use a formula. I kind of go based on all the other clinical metrics that I'm assessing.
What she said.
Okay. So you don't run kind of an hourly infusion or anything like that?
I mean, I have usually my drips going in my effusion, so I can manipulate that, but not as just like a baseline. I still bolus.
Thanks.
Thank you all for being here today. Hope you have a great rest of the meeting.
Thank you.